There are many different causes for impaired vision, but in this episode of OCuTALK, we'll be talking with Dr. Aryeh Pollack about macular holes. He'll explain why the macula is so important to vision, what causes holes in the macula, warning signs to look out for, and treatment options available. Dr. Pollack?
I want to talk to you.
Not now, later.
No, now.
Hello everyone, and thank you for joining us for a brand new episode of OCuTALK. My name's Nick, and today we have a very special guest joining us. From New York Retina and Macula Institute in New York, New York, Dr. Aryeh Pollack. Dr. Pollack, thank you so much for joining us today.
Well, thank you so much, Nick, for having me. It's a pleasure to be here.
Well, it's a pleasure to have you here. Thank you for joining us today. So before we get started, Dr. Pollack, I was hoping that maybe you could introduce yourself to us. Tell us a little bit about your background and your specialty.
Sure. Well, I'm from New York, essentially. I went to Yeshiva University for college. I went to Harvard Medical School. I did my residency at Mount Sinai, which has since become New York Eye and Ear. I did my fellowship in San Francisco at California Pacific Medical Center, which was and I believe still is, essentially really the powerhouse fellowship in Northern California. And afterwards, I came back to New York 22 years ago and opened my own practice. I've been in private practice since.
Well, awesome. Thank you for that introduction, Dr. Pollack. And again, thank you so much for joining us today. Dr. Pollack, for our discussion today, we were actually hoping you could talk a little bit with us about macular holes. But before we get into macular holes, could you kind of start with the macula and why it's so important to our vision?
Sure, of course. Well, the macula is the part of the retina which is most responsible for our central vision. It has the highest density of cones. So I think the best way to think of it is it's a super sensitized digital chip that you would have in your camera, for example, or on your phone. And if that chip doesn't work, or if that chip has a hole in it, then you're not going to really be able to see. Your brain will eventually not be able to get the images, and you won't be able to process imaging.
Well, perfect. Thank you for explaining how important the macula is to us. And thank you for that analogy. I like that, by the way. So now that we know a little bit more about the macula, what is a macular hole?
Well, so a macular hole is exactly as it says, is that there is, as the eponym describes, where essentially there is a gap, or really a hole right in the center of the fovea. But that's actually a really good question. With more advanced imaging we have, what you really see is that it's sort of almost, the analogy I give sometimes, it's a little bit like a broken bone, where essentially the edges of the macula open up and essentially are open, and you still have the photoreceptors at the edges of this volcano, so to speak. And if surgery is done, we can actually close it and restore the vision.
Oh, wow. Again, I'm loving the analogy this morning, Dr. Pollack. Thank you for that. And so, Dr. Pollack, are there any different kinds of macular holes?
There are different kinds of macular holes, but most people generally have the generic standard macular hole. There certainly are traumatic macular holes. For example, if somebody's a boxer or gets involved in a soccer ball injury or an airbag injury, just that the concussive force can basically rupture the macula. But those are not most cases of macular holes. People that are very, very myopic sometimes have a bit of a more complicated macular hole as a result of what's called a macular schisis, a splitting of the layers of the retina. But the standard generic macular hole, it's really one form of macular hole where there are different stages of the macular hole, which is, I think, where the subtleties and nuances of practice can be addressed. But it's sometimes as people get older, there's the vitreous gel in the back of the eye liquefies. When the vitreous gel liquefies, it pulls, and various phenomena occur once the vitreous gel pulls. There can be membrane formation. There's anteroposterior traction. I would describe that as the XY axis, where the jelly is actually pulling the hole open. Sometimes membranes form, and these membranes cause a centrifugal force that opens the hole. There's as well a hydraulic theory, where swelling occurs around the perimeter of the fovea, and that swelling, somewhat initiated by internal limiting membrane of the retina contraction, basically causes the hole to open. But that's basically the generic form of a macular hole that 90 some odd percent of people present with when they have macular holes.
Oh, well, perfect. Dr. Pollack, thank you for explaining the different types of macular holes to us. And so I know, Dr. Pollack, you probably touched on it a little bit while you were explaining it there, but what exactly causes a macular
So
hole?
it's a great question, and that really has really changed a lot of the ways in which we address macular holes. So it's really a multifactorial etiology. Part of it is, again, what I would consider anterior-posterior traction, where the gel is physically pulling, and in the the XY axis, as we are, so to speak, as we're speaking, that opens up that basically causes linear force that opens the hole. Sometimes when the jelly separates, it leaves basically the Mueller cells proliferate. The Mueller cells cause proliferation and make an epiretinal membrane, and it's this membrane that puts traction and opens the hole. And finally, sometimes just the internal limiting membrane of the retina contracts. And when the internal limiting membrane of the retina contracts, it causes a centrifugal force that causes fluid or swelling around the perimeter of the fovea, and this swelling basically pops the hole open.
Oh, awesome. Well, again, thank you for that information, Dr. Pollack, and I appreciate all of the vivid imagery this morning, and it was really exciting. So, Dr. Pollack, what happens to your vision if you do have a macular hole? Like, if I come in and would I recognize if I have a macular hole and be like, hey, I need to go see Dr. Pollack for this?
You would certainly recognize that you're not seeing well. You might not necessarily be able to tell that you have a macular hole. Macular pathology, for example, macular degeneration exists, and some people who think they have macular degeneration have macular holes. So there is a bit of a crossover, so to speak, in terms of presentation of macular pathology. But when somebody does have a macular hole, the central vision is going to be decreased. So the patient would not be able, for example, when looking at somebody, the central face of that person would be, there could be a hole in that face, so to speak, meaning I wouldn't be able to see your nose or your eyes. Now that again could happen with various macular pathologies. Similarly, the straight lines could become distorted actually as well, secondary to an epiretinal membrane that was present. But what's very interesting, what I find that some patients are very, very astute. And I actually had a patient who was a graphic artist actually, and she came in with a macular hole. And she actually came in and presented sometimes what has been described as an early pathologic presentation of a macular hole. She drew a yellow spot for me, actually, as in her vision, with colors, actually. She came in and she brilliantly drew this color diagram exactly of what Donald Gass, who was really who really found macular holes. He was the one who discovered macular holes back in the late 70s, essentially, and early 80s, and described the pathology. He used to call it a yellow spot sign. And she was able to draw this yellow spot sign really very, very beautifully. So sometimes patients will note even a tinge of color in their vision, and that's a sign that they may even have an early macular hole.
Oh, wow, that is a very interesting story. Thank you, Dr. Pollack. I appreciate that. And so now that we know a little bit more about macular holes and how we could probably recognize something, what is your treatment protocol like?
So I'm very biased towards surgery. I mean, you can look people, I'm sure patients will look online, and people look online, and there'll be various medical treatments out there, and we can go through those, such as topical therapy, or there was aquaplasmin was in vogue for a while, which was called Jetrea. But I really think the best way to fix the hole is surgically, especially if the patient comes in early. The best procedure is, in my opinion, is postprandial vitrectomy, where we basically take out the gel from the back of the eye. Okay, we peel whatever membrane is there, and we peel the internal limiting membrane of the retina, and we put a gas bubble in the eye and position the patient. Now, some of these are controversial, I should say. Meaning the question is does every internal limiting membrane have to be peeled in every case? Not necessarily. This is where subtlety comes in. Does every patient need to be positioned? Well, there are arguments in the literature. There are some people that tend to believe that face down positioning was a thing of the past. I tend to believe that I try to use every tool in the toolbox to be able to get this hole to close. So I actually still fill the eye with gas, and I do position the patient at least for a day. At least for 24 to 48 hours, I tend to position the patient. Now, in terms of we can address medical therapy. The new vogue entity is drops for macular hole closure. Now, if you take a look at all macular holes, about 10% of them can close spontaneously. So, and as we discussed, there is a hydraulic fluidic component towards the construction of the macular hole. So in very, very early macular holes, I do think it's reasonable to try to decrease the fluid around the perimeter of the fovea with a steroid drop, non-steroidal, and carbonic anhydrase inhibitor. And that can sometimes help close a macular hole, and sometimes the patient could avoid surgery. But these patients, in my experience, if the patient does have an epiretinal membrane, that will not work. That's just been my experience, and I think that there's more made of this than is actually true. And we'll see. There is a small prospective randomized trial that's being conducted as to the efficacy of drops. The other thing that came out years ago, more than a decade ago, was Jetrio or aquaplasmin, which was actually really a brilliant idea. The point of it was to cleave the vitreous gel, the posterior hyaloid, with the thought that wouldn't then allow the retina to relax. And that does work in some cases. It does work in some cases, particularly younger patients, again, patients without an epiretinal membrane, smaller macular holes. Those patients, it can work. The problem with that is that it's been found to be somewhat toxic to the outer layers of the retina where the photoreceptors are, and there are ERG defects in these patients. So I've tended to really stay away from aquaplasmin if I could. And again, I find that the surgery is much more predictable, and the surgery is you just do the surgery, and 90-some-odd% of the time the hole closes and everybody's happy. That seems to be my experience.
Oh, well, perfect. And thank you for that. And so, Dr. Pollack, you said surgery was your treatment protocol of choice. So what would be the success rate of the surgery? Can it be completely fixed?
Well, it depends what we mean by complete. So in terms of anatomic macular hole closure, there's, especially if the patient comes in early, I would say within 3 months, or maybe even within 6 months, there's a greater than 90% chance, maybe even 95% chance of anatomic hole closure. Now, in terms of what the vision would be with the macular hole being closed, I generally tend to tell patients that it's somewhat idiosyncratic and it's different for different patients. A lot of that depends on how they present. A lot of that depends on still the structural integrity of what we see on examination and upon the OCT of how good the photoreceptors look. But generally speaking, I tell patients that 80% of the time, they could expect the vision to be 50% better. So meaning if somebody comes in and their vision is 20/60, we've got an 80% chance of getting them back to at least 20/30. I mean, listen, I've had plenty of patients that are 20/20 post macular hole surgery, but but you can't promise that. You know what I mean? It's not something that you could really promise any patient. And again, every surgery, of course, has its complications. There's a small risk of retinal tear, retinal detachment, etc. That also, on occasion has to be dealt with as well. So, but nevertheless, in terms of closing the hole, I think surgery and peeling the internal limiting membrane is the way to go. And I think that's really what the vast majority of papers that have come out over the last 10 years have described.
Well, perfect. Thank you for that, Dr. Pollack. And so I know we talked about it a little bit before. We talked about like if someone has this, they're not going to be able to see, like maybe not your nose, and you said like certain facial features, certain
or read even to develop problems reading.
Right.
They'll see a spot. They'll read a book, and they could see a spot right in the middle of the page.
Correct. And so now, let's say, for instance, I have that and it goes untreated. What would happen to a patient if this went untreated?
Well, it's some of it, again, it depends on what the hole looks like. There are some holes that are stable and just stay this way, but larger macular holes, especially this, stage 4 macular holes, perhaps even also in patients that are highly myopic. It is possible sometimes the retina could even go on to detach from the macular hole. That's a possibility. But that truthfully doesn't happen that often. I think the biggest issue is eventual anatomical closure. Meaning if you wait a year from the time that you present with the macular hole, especially if the macular hole is a stage 4 macular hole and a large macular hole, then the chances of closure drop from like 95% probably down to somewhere around 66 to 75%. So because it's just the tissue memory is what it is, after a year. So I think it really is important to try and get to patients that have a macular hole, get to them within 6 months. I think that really is a big difference in their surgical potential of closing the hole and ultimately restoring vision.
Oh, perfect. Again, thank you for that information, Dr. Pollack. And so what new technologies and new developments are on the horizon right now with macular holes or the macula that we need to be on the lookout for?
Well, I'll tell you, that's a great question. I would probably say over the last 5 years, there have been, I wouldn't necessarily say new technology, but just on the basis of just our better understanding of macular holes, it's, in terms of treating the chronic macular holes, we're doing a better job of closing complex macular holes, either with macular hole failures or with patients that have just waited a long time and the hole is very big. So there's certain manipulation techniques of the internal limiting membrane to sometimes stuff internal limiting membrane into the center of the hole. Sometimes we can basically peel the internal limiting membrane and make a flap and create a trap door, so to speak, so it forms a scaffold upon which the hole can close. There's amniotic membrane has been used fairly successfully in papers show very good results with that in terms of taking amniotic membrane and putting it inside the hole. That again forms a scaffold. There was actually one case that I did do of actually even a retinal graft of this patient actually presented with a retinal detachment anyway, so it wasn't necessarily that courageous on my part, but it is technically possible to detach the retina and to actually cut a part of the retina and basically put almost a graft or a transplant on top of the macular hole or inside the hole. And somehow or other, the retina recognizes this and makes connections and can close the hole. So these are all entities that have been described within the past 5 years for basically treating difficult macular holes or macular holes that have been hard to close or have failed in the past. But in terms of what the future holds, and I mind you, meaning the surgery right now is fairly successful again. So if somebody comes in, with macular hole, there's a greater than 90-some-odd% chance the hole is going to close. So there really isn't necessarily that much that's going to be in the future for the standard typical macular hole. We have a great treatment right now. But the future definitely does hold a promise for very interesting possibilities. I would say that optogenetics holds a very significant promise where basically one will be able, I believe within the next 2 to 3 years, to basically take retinal cells that are not photoreceptors, like ganglion cells, for example, manipulate them and basically genetically manipulate them and convert them into photoreceptors. So, wouldn't that be cool if you could take a ganglion cell, for example, or a bipolar cell, and basically have that somehow or other in the peripheral retina, basically take that out, cut that out, and put that inside the macular hole, and then all of a sudden, well, we can make new photoreceptors, because that definitely does limit the vision with macular holes. There almost always is some loss of photoreceptor from the original pathology, because when the jelly pulls, it does take some of the photoreceptors with it often. So if you think about it, if you could find a way to restore photoreceptors, that would be pretty great. Yeah, I think that robotic surgery has nobody's looked at this, but I think robotic surgery has potential, again, in combination with some form of optogenetics. What if we could create split thickness retina, for example, and split a retina and basically take part of existing retina and put that into the hole. So there's all sorts of, then of course there's the bionic retina, which does make every 3-4 years makes significant strides. And in 10 years, 15 years, it may even be possible to completely replace the fovea. Who knows? So I think that this is the next 20 years. But I think patients need to understand they don't have to wait 20 years to get a great treatment. The treatment for macular hole surgery right now is very sophisticated and works very well.
Oh, very cool. Perfect information. Thank you so much, Dr. Pollack. And before we leave today, was there anything else that you wanted to let our audience know about?
Well, I'd certainly like to thank you for having me. I'd like to thank the audience for listening to me. But I think that I would just echo really the what you've stressed in your questions of just simply a call to action is that patients should really see their physicians, especially once they get older especially after 50, and they should see an ophthalmologist every year. And when a macular hole is found, or if they feel symptomatic, then they should come in as soon as possible and get the macular holes treated and get surgery. That's because, again, there's great treatment for it.
Well, you heard from Dr. Pollack. Go see your doctor. Everyone, that's Dr. Aryeh Pollack from New York Retina and Macula Institute in New York, New York. Dr. Pollack, thank you so much for joining us today.
Thank you so much. Thanks a lot.